Welcome, colleagues. Let's talk about something we all deal with pretty much every day in our practice, choosing the best graft for an ACL reconstruction. Today, we're going to dive into a pivotal Level 1 network meta-analysis that provides some pretty compelling, evidence-based answers to this critical question.
Yeah, this is the big one, isn't it? For years, many of us have relied on our training, our mentors, and maybe our institutional preferences to make this call. But what does the highest level of evidence actually say? Well, that's what we're here to find out.
So get ready for a deep dive into the data. We're about to unpack a massive network meta-analysis. We're talking about a synthesis of 45 randomized controlled trials. This is exactly the kind of high-level evidence that has the power to really inform and maybe even change our clinical practice.
All right, here's our game plan. We'll start with the clinical dilemma itself, then we'll dissect the study's methodology. After that, we'll analyze the clinical outcomes, see how the graphs actually rank, and then we'll touch on complications and the study's limitations, and of course, we'll finish with the big clinical takeaway. Let's get started.
We've all had this exact conversation with our patients, right? Trying to explain the pros and cons. With patellar tendon, you're thinking about anterior knee pain. With hamstrings, there's the concern about potential weakness. And of course, allografts come with their own distinct set of risks and benefits. This study should help us navigate this complex decision with a bit more confidence.
Okay, so now that we've set the stage, let's get into the nitty-gritty of the study. To really trust the results, we have to understand how the researchers got there. So let's take a closer look at the methodology. Take a look at this prisma diagram. It's really a testament to the rigor of this study. The authors started with a huge pool, over 1,100 studies, and they systematically whittled that down to just 45 of the highest quality randomized controlled trials. This is exactly what a strong methodological foundation looks like.
And get this, those 45 trials include a total of 3,992 patients. That is a massive sample size, which gives the findings some real statistical weight. It means we can be much more confident that what we're seeing is a real effect, not just a fluke.
All right, now for the part we've all been waiting for. Let's see how these different graphs actually stacked up when it comes to what really matters: patient function and clinical stability. This is where the rubber meets the road.
So first up, let's look at how patients felt about their function after surgery using the IKDC score. As you can see from this forest plot, all the odds ratios cross that line of no effect. In other words, when it comes to the patient's own assessment of their knee function, there was no statistically significant difference between any of the graph types. That's a key finding. Now, let's move to an objective measure of stability, the Lachman test. And this is where things get really interesting. You can see from the data highlighted here, we have a clear distinction. Both patellar tendon and hamstring autografts were significantly better than hamstring allografts when it comes to anterior-posterior stability. And the results get even more dramatic when we look at rotational stability with the pivot shift test. The patellar tendon autograft was the clear winner, outperforming all other grafts. The quadriceps tendon autograft also did very well, proving superior to both hamstring allografts and artificial ligaments. This is a huge deal because controlling rotational laxity is, as we know, a primary goal of this procedure.
So we've seen how the different graphs perform on their own. But what happens when we put it all together and rank them from best to worst? Well, that's the real beauty of a network meta-analysis. It lets us compare all of these different interventions, even if they've never been directly compared in a head-to-head trial. So how exactly do we rank all these different graphs? We use a statistical method called SUCRA. The simple way to think about it is that it calculates the probability of each graft being the number one option. It's a way of synthesizing all the data to come up with a clear winner.
And take a look at this cluster plot. It's a fantastic visualization of everything we've been talking about. On the x-axis, you have patient-reported function, and on the y-axis, you have objective stability. And right there in that top right quadrant, the sweet spot, you can see the clear winner, the patellar tendon autograft. It has the highest probability of being the best option for both function and stability.
But of course, it's not all about efficacy. We also have to consider the risks. So let's take a look at the complications that were associated with these different graphs, as well as the limitations of the study itself. This forest plot gives us a good overview of the major complications. And the good news is, for the most part, rates of things like rupture and infection were pretty similar across the board. But there were a couple of key differences. Hamstring autografts were less likely to fail than tibialis posterior allografts, but, and this is a big but, they were also more likely to cause nerve injury.
Now, it's important to remember that no study is perfect, this one included. And the authors themselves point out a few limitations, like the fact that they didn't look at different surgical fixation methods. And we know that can make a difference. Also, the sample sizes for some of the less common grafts were a bit small, so we do need to keep these things in mind.
So, we have been through a lot of data. We've looked at the methodology, the results, the complications, and the limitations. But what does it all mean for us in the OR? What's the bottom line?
The authors don't mince words. Their conclusion is crystal clear. The patellar tendon autograft may be the most appropriate graft for ACL reconstruction based on both function and stability results. That's a powerful statement, and it's backed up by a mountain of evidence. So, what does this mean for you and your patients? Of course, every single case is different, and we always have to make individualized decisions. But this level 1 evidence is a potential game changer. It gives us a very powerful, data-driven argument to support our recommendations. The question is, how does this evidence influence your next graft choice?